Anyway, at least it's so nice to connect at least this way. So I think this is the first lecture for your batch, but we have been conducting lectures for the other batch. So I hope all of you are well and at least keeping safe at home despite many problems. So without much ado, we will start. One thing I want to tell you before starting why I have put a case vignette is patients don't come with diagnosis. Always they come with a problem. So this is a case vignette of a 25-year-old university student who has facial and pedal swelling for 2 weeks. Her urine was normal in volume and color, because anybody with swellings, you will ask about the urine. Her blood pressure is normal. Jugular venous pressure is 2 centimeters, that is well below 3, which is normal. Cardiac apex is in normal position. And normal heart sounds. Breath sounds diminish in both lung bases. Abdominal, flank and shifting dullness was present. So all of you should not on your mics because it will cause a lot of disturbance. Maybe one or two can answer. What are the problems here? Someone open the mic and answer. So what are the identified problems in this university student? Do you think facial and pedal swelling for 2 weeks is normal?
No.
No, then it's a problem. So there's facial and pedal swelling. Anything else that is found to be abnormal here?
Diminished breath sounds.
Very good. Right. Anything else?
Flank and shifting dullness
What
of the abdomen.
Yes. What does it mean altogether?
Fluid extravasation like ascites and the pulmonary edema.
Yes, breath sounds diminish in the both lungs. When there's ascites, most likely to be pleural effusion, most likely bilateral pleural effusion, right? So percussion note would have given stony dullness. Sometimes when there are very small effusions, you might not have it much. So actually in the context, it looks like there's fluid in the abdomen and fluid in the pleural spaces. So young person coming with ascites and effusion, plus a normal heart. Her heart is normal. So which organs could be problematic? Which organs? Yes? Kidneys could be problematic. Okay, fine. So the possible renal diseases which can give rise to this picture is give 1 or 2 kidney diseases which can give rise to swelling, effusion, ascites. If it is a child, yes?
Nephrotic syndrome.
Nephrotic syndrome. Okay. Is it only nephrotic syndrome? Anything else that you would consider?
Chronic kidney disease.
Chronic kidney disease, very good. Very good chronic kidney disease. What is against the chronic kidney disease? In this, there's something against the chronic kidney disease. One information.
2 weeks history.
2 weeks.
Sorry?
2 weeks history.
2 week history is very against chronic kidney disease. Excellent. Anything
Normal
else?
urine.
Normal urine could be against, but not sometimes, not necessarily. Yeah. Anything else? What about the blood pressure?
Normal blood pressure and normal JVP.
Yes. So those are against the chronic kidney disease. Anything other than nephrotic syndrome? But there are again things against that. Nephrotic syndrome. It's not nephrotic, but something similar. But
it could be nephritic syndrome as well.
Nephritic syndrome as well. What is against nephritic syndrome here?
Facial and pedal swelling for 2 weeks can occur as a result of nephritic syndrome.
Excellent. Okay. What is against?
Urine is normal.
Urine is normal. What do you expect it to be?
Hematuria.
Hematuria, oliguria, isn't it? Again, the blood pressure could be raised, JVP could be raised, but not necessarily. All those things may not be there. So, but blood pressure, again, not elevated is against, isn't it? Right? So, nephritic syndrome, nephrotic syndrome, chronic renal failure, I think all three are pretty much possible, but most likely would be nephrotic syndrome. Any other organ that you could think when there's ascites, effusion, liver, isn't it? Liver disease, like a chronic liver cell disease, isn't it? So sometimes all these things are not related to alcohol. There are so many etiologies for liver disease, such as hepatitis B, hepatitis C, so many diseases. So it could be liver, but less likely. Any other situation that where you could get body swelling for some reason in the spaces? So we need to think of a little wider differential diagnosis before we think. But lot of collections of fluid due to some Starling forces could get disturbed, and then fluid could be accumulated in conditions where there are hypoalbuminemic conditions like severe malabsorptive states, protein losing enteropathies. There are so that is possible, but you might guess that they are very unlikely and very less common causes. So most likely case here. So is there any test that you would quickly do in a ward setting to figure out that this is most likely a nephrotic syndrome? What test would you do here?
Urine ward test.
Very good. So you would do a urine ward test, and actually mostly you can exclude certain causes. So okay.
Excuse me, madam.
Yeah.
No, madam, sorry to disturb. I think the lecture is not recording.
What do you mean recording?
And madam, Raj has said that some students can't join the meeting right now, so it could be recorded and uploaded to the LMS so they can access later.
Sure, you can do that. So how can we do that? You want me to do it? Is it? Can I do it?
Yes, madam.
Okay, under more? Record? Okay, sure. Record needs a permission. I'm not sure how to do it, but shall I get it recorded somehow for you to? I'm not sure how to do it. Sorry about it. Can one of you record it? Can you hear me?
Madam, we also need the host permission to record.
What do you need? Do you need password or something?
No, yesterday, sir, same thing happened to Hirax, and sir claimed to be the host.
Madam, you can click on participants and click on claim host.
Okay. Fine. Host key has to be there, no? Okay. Right. Give me a second to enter the ID and see. Right, we will do it next time. We will do it. Okay, verifying. No. I see how to listen. it's not giving this host keys, something, some problem is going on. Anyway, let's do it without, otherwise we are wasting a lot of time. Right? So therefore we will do it. I'll get it recorded somehow. Maybe I can do it again on some occasion in a blank place and do it, right? So let's, next time, right? Okay, now we will get back to glomerular diseases. You know, glomerular capillaries filter a large amount of water which contain a lot of solutes, and it's a very fine and a delicate membrane. If you can remember the podocytes and the capillary endothelium, how they are together to do this business. And actually, lot of proteins are and large material are excluded from filtration, which is decided by the size of the pores and also the electrostatic charges. So a lot of albumin filter, but they are reclaimed by certain receptors, megalin and tubulin receptors at the proximal convoluted tubule. So that is how the glomerulus works. And many of the glomerular diseases has a lot of different pathogenic mechanisms, starting from even hereditary, mutations, infections, toxins, lot of things, and mostly autoimmunity. So pathogenesis is linked to multiple factors. So if we, in a glomerular disease, if the cause is unknown, we really don't know why, whether it is infection related or autoimmune related or drug related. Likewise, if we do not know the cause, they are called primary glomerular disease. Otherwise, if we know the cause, it could be secondary, something like diabetes. So out of all the mechanisms that I initially explained ultimately lead to a podocyte injury. So podocyte injury will cause losing protein cells via urine, and that is the primary feature of most of the glomerular disease. And multiple mechanisms will interplay, injuring the glomeruli, ultimately ending up with kidney disease, chronic kidney disease. So protein lost, in 80% of the protein lost in kidney disease is primarily albumin, but otherwise there could be immunoglobulins, transferrin, clotting inhibitors, many other proteins which are also lost, less than 20% out of the all protein, mainly albumin, 80%, but other proteins are lost, because these are important to know, because certain other things happen in protein loss in kidney diseases. So that is the pathogenesis. Now presentation. Some people might not have any symptoms. They have asymptomatic proteinuria indicating glomerular disease. Good example would be diabetes, which is not a primary glomerular disease, but secondary. But there is asymptomatic proteinuria for a long period of time, not only as albumin, even 1+, 2+ of albuminuria is again asymptomatic. So asymptomatic proteinuria is one of the features of primary glomerular disease. Then we have nephritic syndrome, the classical. We will go through some comparison in the future. Then we have nephrotic syndrome, right? Where there's gross proteinuria. Then microscopic hematuria, sometimes macroscopic also. Even microscopic hematuria persistently in glomerular origin is a feature of kidney disease. How do you differentiate between a microscopic hematuria originating from glomeruli versus somewhere else in the renal tract, like a calculus? How do you differentiate between the two?
Dysmorphic red blood cells.
That's the way to differentiate. Then suddenly the presentation of primary glomerular disease could be due to an RPGN, rapidly progressive glomerulonephritis, usually with crescents and leading in acute renal failure. So it's very important to remember these presentations, because some of them end up in chronic glomerulonephritis and chronic renal failure, especially for a RPG, and there's only very little time. Immediately, you might have to do something, quickly do a renal biopsy and start on treatment to salvage the glomeruli. Otherwise, the patient will be going into chronic glomerulonephritis and chronic renal failure. So these are the presentations of primary glomerular disease. It is a very wide range. So we are going to discuss only one of them today, but I am sure you know most of them already, but we will only summarize one of them. Right. Now, nephrotic syndrome is the one today's topic. All of you know it's a disease of children, but nothing spares the adults. So adults also have nephrotic syndrome, but it's a syndromic characterization is by proteinuria above 3 grams of protein in 24 hours. So that needs a collection of protein for 24 hours, which is a very cumbersome mechanism. So therefore, spot urine protein to creatinine ratio, UPCR, could be used, again equally compatible to 24-hour collection. So it's validated, then it's compatible. You spot UPCR, that is urine protein to creatinine ratio, about 2000 milligrams, or it can be given as millimoles, 200 milligram per millimole of creatinine, or +3 of dipstick in urine, dipstick protein 3 pluses, also could be nephrotic syndrome. So heavy proteinuria, along with heavy proteinuria, there will be hypoalbuminemia because the liver will not be able to synthesize. You know, liver is the only organ which synthesizes albumin. There are many mechanisms which inhibit synthesis of albumin. And then along with high proteinuria and hypoalbuminemia, there's edema and hyperlipidemia, which is as LDL cholesterol as well as triglycerides. Both are elevated. So these are the classical syndrome of nephrotic syndrome. All of you know that. But there is also lipiduria, hypercoagulability, malnutrition, hypocalcemia, and a lot of infections. So nephrotic syndrome is a chronic and disabling disease, right, which goes along for a long time period, distressing for the patient and distressing for the family. So I would list it as a chronic disease. So adult with nephrotic syndrome, a clinical presentation is just like that case I gave, facial and pedal swelling. Facial swelling is more in the morning, proteinuria in an adult. The cause could be not like in children, not like commonly minimal change. So therefore, there are other kinds of etiologies for adult nephrotic syndrome, which can ultimately be impairment and also hypertension. So adult nephrotic syndrome is quite different from adult children. So therefore, let's look at the differences between nephrotic and nephritic presentation. This is a question which is very often asked at the exams, and a prompt reply without thinking is required, because a student who had been working will quickly tell in a nephritic syndrome there's edema, but hematuria, oliguria, evidence of fluid retention in the intravascular compartment. That is important. Whereas in nephrotic syndrome, the fluid collection is mostly in the spaces, right? So therefore, pulmonary edema and raised JVP, and then elevated blood pressure because there's salt and water retention due to reduced urine output, and impaired renal function. So nephritic syndrome has this collection, whereas nephrotic syndrome, blood pressure could be normal or low, and because of sometimes reduced oncotic pressure, the patient may be a little dehydrated even, right? Volume, intravascular volume is less. Then generally normal renal function, but not necessarily so, but also hyperlipidemia. So this is the nephrotic versus nephritic picture. I hope it is clear to everyone. This is not a new thing. I mean, pretty common, but commonly asked question. Right. So in a history, now let's look at that girl's history. Frothy urine is mentioned, not much mentioned in books, but it's a common observation. So frothy urine may be there. It's not a very classical symptom, but color and amount. Note that oliguria can occur in later stages because of reduced renal perfusion, because of reduction of blood pressure and perfusion pressure because of reduced serum albumin. So oliguria can occur in later stages of nephrotic syndrome, which is very severe. Then periorbital puffiness, which is worse in the morning, which is a very classical feature of nephrotic syndrome. And then there's features of uremia and shortness of breath. It's important to check on features of other systemic diseases. You know, some of those things are like rheumatoid, SLE, mixed connective tissue disorders, thyroid disease, many diseases, including malignancies and infections that they might have had in the past or maybe currently having. So important to record the systemic diseases. Past medical history, similar episodes, and it's important to know about diabetes because that could be treatment related or maybe the etiology of the renal disease. Then hypertension, hepatitis status. Lot of drugs can cause. Most of them are like penicillamine and gold, classical causes of nephrotic syndrome, but they are no longer used. But the drugs that are used, I have listed. Don't forget NSAIDs. It's a very well-known cause of glomerular disease and membranous nephropathy, minimal change, both could be caused by NSAIDs. Lithium, bisphosphonates, captopril, sometimes clopidogrel, a lot of drugs can cause glomerulopathies. Then family history is important. Some certain things are familial. And important to check for complications of the disease as well. So these are the historical things that you always do. And also in a checklist for examination findings, I have reduced a lot of things, put on the important. Don't forget that the moon phase could be due to steroids and striae and bruising could be due to long-term steroids because you might not come across, it's very uncommon that you will come across for a patient with the first time. Most likely in a clinical setting for an exam setting, you will get a person who had been, having nephrotic syndrome or renal disease for years and years with many exacerbations and remissions, and it's extremely difficult to record a history because there had been so many life events in the patient. So what we advise you, if there are so many events, so what you can do is the initial thing and maybe several significant things and the frequency of events. So recording could be, history recording is generally very, very long. So therefore, it's important to record treatment-related effects which are obviously visible in the patient. So pallor might indicate the patient is going into kidney disease, chronic kidney disease. Then eruptive xanthomas, especially in a patient with nephrotic syndrome because of hyperlipidemia. Evidence of DVT. Note, then blood pressure, jugular venous pressure, cardiac apex, lung bases for dullness and fluid, and ascites and abdominal tenderness. So these things are the important general features in any nephrotic syndrome, but also you might have to look at and record the patient's other features indicating that there is another etiology, giving a clue to the etiology, So that is the checklist for examination findings. And then investigations. I'm sure you know most of these things, but we will quickly go through investigations. Urine for albumin and deposits is important. Spot urine protein we discussed already. And 24-hour urine protein estimation and serum albumin. Lipid profile, then the general biochemistry. Do not forget the electrolytes because there's a lot of things happening in the kidney which will change the electrolytes. It's a very important day-to-day investigation. This is a day-to-day investigation. Blood count, blood sugar, ESR, renal ultrasound might show large kidneys in the early disease. But later on, if the disease is progressive, you might see contracted kidneys later on. ECG, Doppler scan of the lower limbs because there's a high tendency for DVT. We will discuss why. And then as investigations for other cause, there are many investigations that you might have to record, like the complement levels, further autoantibody status. I have listed only a few, at least ANA and a double-stranded DNA. If these things are, if it is your exam patient, you might have to tell at least the ANA, dsDNA, rheumatoid factor, hepatitis B and C status. Don't forget HIV. So these are common causes of secondary nephrotic syndrome, right? So investigations, this is the usual set of investigations, right? So now we come to the proper glomerulopathies causing adult nephrotic syndrome. At the end of the lecture, you will have to answer a few questions. So these are the renal diseases which present as adult nephrotic syndrome. So please do not, if somebody asks this question, please give this appropriate answer without telling many glomerular diseases that you know. So first and foremost, membranous nephropathy, membrane. We are going to look at the membrane later. Then focal segmental glomerular sclerosis, FSGS, focal segmental glomerular sclerosis, and minimal change disease. So these are the three commonest presenting nephrotic syndrome. In a child, minimal change nephrotic syndrome is the most common, 90%. Membranoproliferative generally is nephritic, but some people can have a nephritic-nephrotic overlap, right? So that will be the last. So there are, these are primary glomerulopathies, but there are secondary causes of nephrotic presentation, like a very advanced diabetic nephropathy. Very advanced diabetic nephropathy. So diabetic nephropathy is not an immune cause like the ones that I described. In primary glomerular disease, there is some immunological phenomenon going on. Diabetic nephropathy, there is no immunological phenomenon, only basement membrane thickening and leaking. Therefore, even in advanced diabetic nephropathy, you will only see protein. You will never see red cells and pus cells. It's important distinction. If you see in a diabetic nephropathy, red cells and pus cells, that indicate something else, such as, give an answer.
UTI.
Very good. UTI. Pus cells, red cells could be urinary tract infection. So, but or else it could be some other cause of glomerulopathy overlapping. So in that case, if it is a persistent in a diabetic patient, if you have excluded the renal infection, there may be an indication for a renal biopsy. So diabetic nephropathy is a secondary cause, generally not listed as a primary glomerular disease. Amyloidosis, again, no inflammation going on, very inactive, no sediments, only protein. So they are, we are not going to discuss them much, but we are going to concentrate more on primary glomerular disease. Right. Now in the kidney, there's not only glomeruli, but there is also tubules. Tubules also have that protein. Can one remember the tubular protein name? Very good. Sam-Hosford protein in tubule. But tubular proteinuria is never nephrotic range. So it is never nephrotic range. Tubular diseases also, like interstitial nephritis, is something tubular disease. They will never cause nephrotic range proteinuria. In a person, there could be little proteinuria, like when waking up, when they have fever, when they are walking, but always it is less than 150 milligrams per 24 hours, right? So Orthostatic proteinuria, they call it. But if it is more than 150, that is abnormal. Right? So therefore, there's another mechanism where you can get proteinuria, such as in a light chain, overflow proteinuria, light chain myeloma. Myeloma, you can have light chains filtered in the protein, urine. So these are few facts that need to know. So primary in adults, nephrotic syndrome, mostly the biopsy. Adult nephrotic syndrome of unknown etiology need a renal biopsy, not like in children. If the cause is obvious like diabetic nephropathy, you should not biopsy. So that is important to remember. So indications for a renal biopsy is if it is not within that minimal change nephrotic syndrome age range, that means either less than 1 year or above 10 years, that is an indication for a renal biopsy. Then if there is significant hematuria, casturia, hypertension, there is a nephritic features, then again, you need to know the etiology. So biopsy is needed. So even if there's a nephrotic range proteinuria, but there are red cells, pus cells, that means the etiology could be nephritic, something like even RPGN. So most adult nephritic syndromes, nephrotic syndromes need a biopsy. Something will not need a renal biopsy would be something like a post-infectious glomerular nephritis, where you see even the scars of healed wounds are already seen. So that is a acute diffuse proliferative glomerular nephritis. Still we see in some adults who are mostly outdoor people coming with nephritic presentation. So those patients might not need a biopsy, but you have to remember most of the adult renal diseases need presenting as nephritic or a nephrotic need biopsy. So if there's, even if you think it is a minimal change and not done a biopsy at the first instance, if the steroids are not responding, then that indicate non-minimal change disease need a biopsy. Frequent relapsing and remission, frequent relapses need a biopsy. If there's abnormal serology suggesting that it could be SLE, need a biopsy. So there are most of the adult nephrotic syndrome will ultimately need a biopsy unless it is a very simple case where it's settled quickly with steroids. Okay, we go to the next session. So that is, we will start with 1 or 2 glomerular diseases. So I will start with minimal chain nephropathy, though that is not the commonest cause, right? So this is minimal chain. This is typically present as nephrotic syndrome. So some people call it minimal chain nephrotic syndrome. Minimal change nephrotic syndrome. So if you can remember that, you will need to remember the presentation as well. Then 80% children less than 16 and 20% in adults. It could be 20% in adults. So it's not the commonest cause of nephrotic syndrome in adults. Peak age is given 6 to 8 years. Normal renal function, normal blood pressure, mostly idiopathic. Rarely associated drugs like NSAIDs, malignancy, lymphoma, HIV. Normal complement levels because there's no immune complex deposition as such, right? And then you can see that it looks left and right pictures of a normal glomerulus viewed by a routine microscopy, but in a routine microscopy, there is no cell infiltration, there's no membrane thickening, but they are generally seen in electron microscopies. But routine microscopy doesn't show anything much, but electron microscopy will show changes like podocyte fusion. So that is minimal change. Light microscopy, normal histology. I think all of you know, but I will quickly go through as a refresher. The effacement of food processors, no immune complexes or antiglomerular basement antibodies deposited. How can we see these immune complexes? How do we see these things? How do we see these things? In which microscopy?
Immunofluorescence.
Yes. Immunohistochemistry you need to do, immunofluorescence microscopy. So therefore, if you want to do certain things, how the clinical it affects it would be, even if you do a biopsy, you should not be sending it to a place where that facility is not there. So therefore, you need to send the biopsy sample to a certain place. We used to send it to Peradini if it is a hospital sample, or if the patient can afford, to a private sector big laboratory where immunohistochemical staining of the renal biopsy sample could be done, right? So always you have to mention that. Certain components are done at Faculty of Medicine as well, but not all the components. So therefore, before you do the biopsy, you need to discuss these things and where you have to send. So that is why it is important. Then highly selective proteinuria in minimal change, there's only albumin. These are very common MCQs. So these things have to be remembered. So treatment here, minimal change, largely, it is steroids are the mainstay of therapy, but I'm sure you have learned it in pediatrics. Before that, before we go to specific treatment of a nephrotic syndrome, let's concentrate on general management. I would mostly worry about these patients' psychological status and this chronic disease situation, right? So actually we can list out the management like this, do this, do this, do that. But what really needs is a very genuine and a supportive care for these patients. So general management, when somebody comes with body swelling, all of you know that we need to check the weight, because swellings appear when 2 kilograms of 2 liters of water, which is equal to 2 kilograms, exceeding that amount. So swellings appear after you have collected 2 liters. So therefore, daily weight is the most important, and whoever is swollen needs fluid restriction and monitoring urine output and input. Salt restriction, and then they are losing protein. If there's no renal impairment, their protein intake has to be improved to about 1 gram per kilogram per day, like a 50 gram, 75 gram protein. Not too much, because in certain studies, animal proteins actually progress the renal disease according to certain, but these are not very much evidence-based. But mostly vegetable and fish would be better, because otherwise meats contain a lot of fat as well, which is not very good. So then diuretics are important, but remember in nephrotic syndrome already reduced oncotic pressures. So therefore you have to be very careful in using diuretics. So loop diuretics will lose a lot of sodium and potassium. So in combination, you can use loop and potassium sparing diuretics very cautiously, very cautiously. Then statins, either lower level statins. Rosuvastatin, there are claims that it could be not so good in certain papers. So therefore, atorvastatin is the choice. Statins to control the lipid status. Otherwise, the patient will have accelerated atherosclerosis even as a child or a young adult, and have a drastic consequence. So therefore, statins have to be prescribed for patients with nephrotic syndrome. Right, now I have to ask a question. What about giving albumin? What will happen to the albumin? If you infuse albumin, there's salt-free albumin which you can give, which is available, costly. What will happen if you give salt-poor albumin in a patient with uncontrolled nephrotic syndrome? Can we give? I'm sure we can give. There's no contraindication. But what will happen? Use your common sense.
They will also get loosed in the glomerular?
Absolutely, they will be filtered in the urine. So they are of doubtful value, but in certain instances, proteins are very low. You might have to try it while you are treating the patient. So that is as much as you give in acute disease, it will be filtered in the urine. So it's actually, in reality, it is waste, right? but we don't know how many percentage will be lost. Not all, maybe some may be retaining still. So there may be in a patient who is very severely hypoalbuminic, there is still a. Then AC inhibitors are very well known to reduce the intraglomerular pressure, therefore reduces proteinuria in many diseases, almost all the diseases. AC inhibitors are very well known causes which reduce proteinuria. Then blood pressure control is important, either ACE or A or B. There are contraindications like hyperkalemia, renal impairment. But blood pressure control using a non-dihydropyridine calcium channel blocker. Calcium channel blockers could be used for blood pressure control, right? And then there could be many other drugs also could be used. I have listed these two. Then in certain times, you might have to anticoagulate these patients. I will tell you when to anticoagulate. Anticoagulation or giving warfarin, aspirin, those are not common things for a nephrotic patient, but there are instances that you might have to consider, right? And then always check the electrolytes. Electrolytes might have to be checked daily. Renal function may not be so daily. Urine albumin, urine protein, you can check what test daily or dipstick daily if there is available. So this general management will include all these things, and also vaccination for pneumococcal vaccine and penicillin prophylaxis, especially in patients with ascites. So this is the general management of the any patient with nephrotic syndrome. Let's look at the specific management. I'm sure you know, but there's no harm learning it again. So the guideline is KDIGO guidelines. I'm sure you know all these things. That is the reference guideline that I have used for presentation. So minimal change nephropathy, you use prednisolone because it is immunological. You use prednisolone either as a 1 milligram kilogram is the one which for many diseases. So you have to remember that 1 milligram kilogram per day is the dose of steroids, which is you might not want steroid related side effects. Therefore, you might give a higher dose every other day, but to a maximum dose 120 milligram per day. Even if the patient is obese, don't go beyond. And for a minimum of at least 4 weeks. Might have to continue for 4 months, depending on the response. So in a minimal change, if the case is minimal, there's a remission in more than 90% of patients, which you can slowly taper over 6 months. There are so many regimes to taper, and the patient might be in remission and be cured of disease, and that is our wish. But in reality, when you tail it off, it might relapse. Also, it might be not in immediate, it might relapse after some time. If infection going on, it can relapse. So there are many instances which it relapse, and those are the patients that you see as your clinical cases. And then you might have to repeat the depending on how bad the relapse is, right? Because if it has after quite some time and has responded very well to initial prednisolone, you might have to repeat the prednisolone treatment as usual, or else these are high-end kind of discussions which need to be done with a nephrologist. So there are second-line agents which are used like cyclosporine, nowadays tacrolimus, MMF. These are the drugs, second-line or third-line drugs that can be used. In the cohort where there is a failure, 90% will respond, that is very good, but 10% will not respond. Then you will have to treat these patients or whatever. So therefore, those people also can have second line agents, and it's a long treatment period. So ultimately, so this is the basic treatment regime for a minimal change nephropathy. So remission, how fast? In 1 or 2 weeks, they will become better, right? But some need longer courses, and some 50%. relapse on steroid withdrawal. 50% relapse on steroid withdrawal, so you need to go for a second course of steroids. And also 50% remain corticosteroid dependent. They need at least a smaller dose of steroids. When you are tailing off, there's a point that the proteinuria might appear again. So therefore, you might have to continue steroids for a longer time. So that is the response to treatment in a minimal change in an adult. Right? So there are second line agents, as I mentioned, for frequent relapses. Cyclophosphamide can be used, cyclosporine, MMA, and tacrolimus mentioned. So this is the basic treatment design for minimal change. You might have to know some of these things, especially in pediatrics. So let's move on to the more important nephrotic syndrome in adults. There are a lot of disturbance going on. Can you hear me clearly?
Yes, madam.
Okay. So membranous nephropathy. Nearly close to half of the nephrotic syndrome in adults is membranous nephropathy. So if you are again asked common causes, please give membranous nephropathy as the first cause of adult onset nephrotic syndrome. But it is less common in children, and diffuse thickening of basement membrane is there. So diffuse thickening of basement membrane is there. I am sure you have learned in your pathology. There's basement membrane thickening, right? So you can see the normal glomerulus. Nice looking glomerulus, very thin glomerular capillary basement membrane, very thin. Whereas in membranous, it looks a little thicker. And when you look better, you can see a very thick basement membrane here. And the cause is, this is the real membrane. You can see the real membrane, thickened basement membrane in this glomerular section. And it is due to various subepithelial deposits. Certain things are getting deposits, though it is looking like a membrane. When you look at electron microscopically, these are actually certain dot-like deposits, which are immunoglobulins and complements. IgG and complements are the things inside these deposits. So though it looks like a membrane, it is containing lot of deposits. So light microscopy will have diffuse thickening, but in electron microscopy and immunohistochemistry will show IgG and complement C3 along capillary walls. So that is a membranous nephropathy. So these questions might come on at very, very odd places. So you need to remember these things for your life, right? So I said etiologies could be of a membranous nephropathy, could be many. So starting with SLE, rheumatoid, MCTD, dermatomyositis, ankylosing, all the rheumatoid diseases you can list, like thyroid disease, everything you can list. Other than those, hepatitis B and C are notorious diseases which are very chronic, not only causes renal disease, but also causes bone marrow disease. Bone marrow disease. These two cause liver disease, renal disease, and bone marrow disease. So all three. HIV again similar, right? Again similar known cause of membranous nephropathy. Malaria, filaria, syphilis, leprosy, these are mostly being eradicated now, but they are known causes of nephrotic syndrome. Then there are solid tumors like bronchial carcinoma, ovarian carcinoma, uterine malignancies, many breast cancers, they can cause membranous nephropathy. Lymphomas can cause membranous nephropathy. So don't forget that drugs, many drugs like NSAIDs, gold, penicillamine, lithium, captopril, clopidogrel, many drugs also can cause a membranous nephropathy. So these are the etiologies. You might have to look for some of those by doing investigations. Right. So let's see whether membranous nephropathy also respond like that. Actually, membranous nephropathy, it's very unfortunate. Only 40% will remit. So 60% will not remit. So those days when we were students, we learned it as a 30% rule. Now the 30% has really changed because spontaneous remission in 30%, 30% has remission relapses, and 30% will end up as renal failure. If you have difficulties in remembering, you can remember the 30% rule. 30% will become cured spontaneously, 30% will end up as chronic renal failure, and other 30% will have remissions and relapses, right? So that is the outcome of membranous nephropathy. Poorly prognostic categories would be male, old age, hypertension, dyslipidemia, renal impairment, and these are anyway known causes of poor prognosis in most of the diseases. Anyway, let's see whether it is treatable. Let's see whether it is treatable. It is treatable, but treatment is not given for everybody because not like minimal change, membranous nephropathy is not readily responding to steroids. Steroids in that doses are really toxic. Steroids in that dose will definitely cause diabetes because Asians have a very high risk. So diabetes, osteoporosis, infections, and the mortality and morbidity of steroids will be very high. So therefore, in studies, steroids have not shown any consistent improvement. Therefore, initial therapy is started only in patients who present as nephrotic presentation and a high protein excretion, right? And remain 50%, not 500, right? 50% above baseline protein excretion every day. It's very high, and there's no reduction of proteinuria with blood pressure control and AC inhibitors. So in membranous nephropathy, the treatment is reserved for people who are not doing well, but other people just observe and wait. Observe and wait. Why? 30% will spontaneously improve, right? So if you have decided to treat, then initial therapy is alternate cycles of steroids and chlorambucil, right? So, or cyclophosphamide. So, alternating cycles, monthly cycles of steroids and either of one of these, cyclophosphamide, chlorambucil, or maybe a regime with cyclosporine, right? To reduce the proteinuria. The aim is to reduce proteinuria and slow the progression of the renal disease so that the patient is actually living with that kidney as long as he could. So prognosis of membranous nephropathy is not so good. Ultimately, the patient might end up with renal failure, needing a renal transplant. So remember that. Okay, so membranous nephropathy is very much different from minimal change. Right, this is the one which is of very quite interesting. Focal and segmental glomerular sclerosis. You often forget this disease as a cause of nephrotic syndrome. Right, focal and segmental glomerular sclerosis, and it is idiopathic, but again, heroin use is associated, FSGS, right? Then there's drugs, right? Idiopathic, HIV, diabetes, various other causes, like even a single kidney can cause some glomerular sclerosis. So actually, pathognomonic is sclerosis and hyalinosis of portions of less than 50% of glomeruli. And it is actually showing increased incidence in adults, now progressively increasing. So the common nowadays in adults would be membranous and FSGS. So this is a picture where it shows inflammation going on ending up in sclerosis. So you can see segmental sclerosis in, I'm sure you have studied most of these things in your pathology, segmental sclerosis in focal segmental glomerular sclerosis, right? It can recur It is a disease. Certain diseases recurs in a renal transplant. Say some diseases, even if you put a new kidney, the original disease will recur in that new kidney also. Give one example. One is FSGS. Another example. Can you give another example where the original disease will recur in a transplanted kidney? Can you think of any cause? Okay. What about antiglomerular basement membrane disease? Because antiglomerular basement membrane antibodies will be there, and a new transplanted kidney also can have antiglomerular basement membrane antibodies attacking that new kidney's glomerular basement membrane, because it also has a therefore that disease had to be treated before you treated, an antiglomerular basement membrane antibodies had to be made to zero, I mean undetectable levels before you transplant the kidney. So treatment of FSGS is important because it is recurring in the transplant. These are very common MCQs, right? Multiple choice questions for your exam. So steroids and cyclosporin are the main treatment, right? Again, you can try prednisolone and various other immunosuppressants as mentioned, but very variably effective. Variably effective, not so effective. So, okay, so now we have covered 3 major causes of adult nephrotic syndrome. And then non-immunological glomerular diseases also you need to know, like diabetic we discussed, right? Basement membrane thickening is the cause, non-inflammatory, no positive deposit. Remember that forever, right? And then glomerular sclerosis can happen in hypertension. Hypertension can cause glomerular sclerosis and renal impairment and proteinuria. Then certain toxins can cause, those are non-immunological glomerular injuries. Drugs, again, can cause glomerular injury by different mechanisms. Depositions like cryoglobulins and amyloid, both are known to cause glomerular injury, infection, and inherited Alport syndrome. These are non-immunological glomerular injuries. And thin basement membrane disease, again, a hereditary cause of nephritic and a nephrotic syndrome. Alport syndrome is associated with what physical sign? What symptom?
Deafness.
Yes, deafness. So, deafness. So these are non-immunological glomerular injuries. I have just put a list, maybe not so relevant here. Okay, let's look at the complications of the spelling mistake, complications of nephrotic syndrome. I told you it is a very long-term illness with a very high morbidity, right? Venous thrombosis, right? Venous thrombosis occur, especially with heavy proteinuria. When there's heavy proteinuria, membranous nephropathy, early in the disease can have venous thrombosis, and classically you will have sometimes a patient will have a renal vein thrombosis, right? How does a renal vein thrombosis be recognized in a clinical setting in a patient with nephrotic syndrome? Renal vein thrombosis.
Patient complains of sudden abdominal pain.
Yes, exactly. Very good. Abdominal pain and severe
Hematuria.
yes, exactly. One-sided abdominal pain and hematuria. One-sided abdominal pain, if that same nephrotic syndrome person has come with severe abdominal pain and hematuria, that is a renal vein thrombosis. Right? It's important to remember. Then protein malnutrition can occur. That is why you really need some good quality proteins for their diet. Hypovolemia, AKI infection, we already discussed these complications, right? Okay, now if you have questions, you can be ready with the question. So we covered nephrotic syndrome in adults and went through the clinical presentation, etiologies, little bit on the histological aspect, and the management and complications. So this is what you really need to know regarding this. So we will now, before we end up, we need to know a couple of questions which I would like to know your thoughts. And then you have to always remember these presentations are very diverse, right? And no one will come and tell you that you have nephrotic syndrome, and it is the doctor's skill and clinical judgment and the careful use of investigations will only lead to a diagnosis, right? So therefore, let's look at the question. Okay, I am sure at the end of this lecture, you are able to give 3 causes of adult nephrotic syndrome. Can one answer? 3 commonest causes of adult nephrotic syndrome?
Primary causes, membranous glomerular nephropathy,
Yes.
focal segmental glomerular sclerosis,
Yes.
and minimal change disease.
Excellent. Excellent. So those are the 3 causes. Okay. Explain the reasons for increased risk of infection in nephrotic syndrome.
Because they lose many immunoglobulins with urine.
Very good. Very good. Many immunoglobulins and complements are lost in the urine. Any other reason? Treatment related?
Immunosuppressive
Steroids.
Yes, they are always under immunosuppression, isn't it? Many complements which are sometimes needed for opsonization are lost, and also immunoglobulins are lost. So therefore, antibacterial products are lost in the urine. Therefore, they are more common to get pneumococcal disease, capsulated bacterial infections. Also, don't forget, sometimes tuberculosis, TB peritonitis, in especially patients with nephrotic syndrome, either pneumococcal, tuberculous, peritonitis is common. So because that is where the fluid is collecting. So reasons, and also the immunosuppressants, especially the steroids and other immunosuppressants. Okay, explain the reasons for increased coagulability in nephrotic syndrome.
could be due to multiple causes. There's lots of anticoagulant proteins like antithrombin 3.
Very good.
And there's increased production of procoagulants and anticoagulants because there's loss of albumin, so the liver goes into like increased synthesis of these clotting factors as a result of hyperalbuminemia.
Okay. Okay. Anything else? So anti-clotting proteins like antithrombin 3, protein C, protein S, all these things are lost, and increased synthesis of factor fibrinogen is increased in 1, 2, 5, 7, 9, 13. Many clotting proteins are increased synthesis along with synthesis of lipids and albumin. So that is one reason. Okay. So fibrinogen excess. So that could be increased coagulability. Anything else that you can think about?
Hemoconcentrated state.
Hemoconcentration, absolutely. Hemoconcentration because of relative low volume status. Relatively low volume status. Increased coagulability, ill bed bound, isn't it? Ill bed bound again promotes the deep vein thrombosis. That is reduced mobility because of swelling and various other reasons. And also membranous nephropathy. Membranous nephropathy, especially with heavy proteinuria, more the proteinuria, more likely to be having a thrombosis. So in certain instances, if there is a high thrombotic risk, there may be places that you might have to anticoagulate. So those are the reasons for increased coagulability. So I think we are coming to an end. I hope, because it's a very common topic, I will not go through with another summary, but I am sure you can clear your doubts. Whatever your doubts, you can clear now.
Madam, I have a question. You mentioned that penicillin prophylaxis is given for ascites. Why? I don't understand that.
Okay. Again, similarly, people who have pneumococcal disease, they are high risk of pneumococcal disease. That is why the penicillin prophylaxis is advocated in patients who are recurrently having a considerable amount of ascites despite therapy. You might have to give anyway penicillin prophylaxis, more than that pneumococcal vaccine, because of pneumococcal prevention of pneumococcal infection. Okay.
Okay. Thank you.
Any other questions? Right. If you have any questions, I think we should open a forum, and if you don't want to ask here, maybe ask. Maybe you could post it. Post questions to. I will forward an email address, so that what you can do is you can post questions, because all of us are free nowadays, not doing much work. So therefore, I am sure we can support your learning. What I will do is I'll get this first thing, I'll get it recorded back again. And then I will get Dr. Heyrat to post, give a mail address, so that you can post your questions. Is that okay? Anything else that we can be helpful of? So anyway, it's really, I'm so glad that we are, you all are here. More numbers than a lecture hall will accommodate, because most of you are not there for the lectures, but at least you seem to be preferring this mode of learning. Only thing is it gives us a little less interaction, and I'm not sure about the clarity of the lecture for everybody who seems to be, who might not have an excellent connection. So to support learning, I'll get it recorded, as I said, and then we will continue at, like in this form. We have some light at the end of the tunnel. Okay then, right. Thank you very much.
Thank you, madam.
Thank you, madam.
Yeah, all of you talk to yourselves.